So good morning, my name is Flavia Ramos. I'm a general trauma surgeon here in Rio de Janeiro, Brazil. And we'll be presenting a case about a splenic trauma management. I'm here with my third-year resident, Monique.
Hi, good morning. My name is Monique Graziel, and I am the Rio General Surgery resident do Estado Pereira.
Okay, Monique, you can go. So basically, we're going to describe in detail the diagnostic and treatment interventions in splenic trauma, and we'll be analyzing the strength and weakness of treatment modalities and the lessons we have learned with this case. So we had a 53-year-old male who was admitted at our hospital. His main complaint was upper abdominal pain associated with pain in the left shoulder and fever in the past 2 days. He had a history of a blunt thoracoabdominal trauma. He had a motorcycle accident like 15 days ago, and he was treated in another hospital. And there he had a splenic injury, grade 3, a grade 2 liver injury in the left lobe, and multiple left rib fractures, as you can see, 3rd, 4th, 5th, 6th, 7th, and they decided to do a non-operative management. So he was discharged, he went home, and he wasn't feeling well, and he decided to come to our hospital because it was near to his house. Monique. So he was admitted in August 9th. He was stable, as you can see. He was oriented, a bit pale, and afebrile. He had a tenderness in the left upper quadrant, but no rebound. His labs, he had 8.9 hemoglobin. His crits was 28 and 21,000 leukocytes. And he, in here, we use more of a, sorry? Sorry?
Sorry, Flavia, go ahead.
Oh, okay. And in here, we use the proteins reactive C. It was 19.9. So what do you think we should do? What would you do with that case?
Dr. Antrach?
Yeah, so in my exam, usually as part of my exam, I do an ultrasound, and I would do it here, but ultimately this is going to come to a CT scan, knowing that he had a splenic rupture grade 3, and but now he's febrile leukocytosis, so I would expect that he has an abscess or an infected hematoma abscess for the same thing. So he would certainly come to that, and right, he's hemodynamically stable, and so it's more of a chronic complication. But that would be next, CT scan. And not seeing him, I don't know about the antibiotics, but I would do the CT scan first.
Thank you, Dr. Antrach. Dr. Fraga?
I have a question. When he was treated with non-operative treatment, was at the same hospital, or the patient was treated in another hospital?
So he had a trauma and he went to a different hospital. We don't know for how many days he was there. And we only know that he was discharged after a few days. He doesn't remember. He didn't remember at the time. And because he was feeling ill and febrile at home, he decided to come to our hospital, our unit, because it was closer to his house. So we don't have that information. Okay.
You don't have access of the exam, the CT, in the another hospital?
No.
The patients?
No.
Okay. I think this is a problem that you have in some place, like in Brazil, is sometimes very difficult to have the follow-up of the patients. The patients are treated in one hospital, and they are discharged. Usually, there is a outpatient clinics, and the patients receive orientation to come back to the same hospital, but sometimes they go to another hospital, and we don't have a electronic chart where you can access the exams in the other hospital. I think this information probably is important in this case because he has a complication of the non-operative treatment. Probably he has a splenic abscess. And if you have the image in the previous hospital, I think it's good for decision. 15 days after the trauma, I think it's a complication of the spleen. But when the patient come early, 1 week after trauma, sometimes the patient can have a missed injury. So in this case, the patient is stable. I think it's very important to have a CT of the abdomen to make the decision. And the patient has some signs of infection because C-reactive protein, the costs are 21,000. So the first hypothesis is about a complication like abscess in the spleen. Thank you.
Thank you, Dr. Fraga. Dr.
Yes,
Supa?
no fever, no fever. Just to remember, there's a question in the chat. No fever, Flavia. No fever.
When he arrived, no fever. He told us he was febrile at home, like 38, 39 Celsius.
Okay, at home he had fever. Perfect. Thank you.
Thank you, Dr. Fraga. Dr. Supa, would you like to comment?
I think he may have complication of splenic injury, like abscess or even delay rupture of the spleen. He's hemodynamically stable. We should send him for a CT scan of the abdomen. Thank you.
Thank you, Dr. Supa. Dr. Kasim, Portland?
Well, good morning. This sort of thing was very common in the United States. About 12 years ago, Mr. Obama instituted a program where hospitals share information with each other, and he spent billions of dollars doing that. And now that system is working very well. I can get information on a patient who comes to my hospital from another hospital in a matter of seconds, minutes. Same information is available for any other hospital in the United States. That's something that you should know about. So this is a problem in all developing countries where hospitals don't share information, because now you have to reinvent the wheel. You have to go through the same thing all over again. So let's look at this case. He was in the hospital 15 days ago. He got discharged. Now he's in your hospital and he doesn't look good. He has a hemoglobin of 8.9, hematocrit low, his white count is 21. So you have to start from the beginning, which is enormous expense for you and for your country. Second, so first thing I would do, I would try to get the information from the hospital, even though it may not be available to you. Second, I think you should do a chest X-ray first, because with splenic injury, rib fractures, you may have a problem with your left lobe of the lung, and it could be atelectasis, or it could have pneumonia, who knows? And then you should do some blood cultures to make sure that the blood cultures are available for you for the future if you have to analyze that. And then you're thinking about something wrong with the spleen. Obviously, he's lost a lot of blood, his hemoglobin is down. So he has an infected hematoma, or he just may have a collection which is causing him to increase his C-reactive protein and not do well under the left diaphragm. So CT scan is most appropriate in a situation like this. But before that, you also should do blood culture examination, chest X-ray. Thank
Thank you, Dr. Kasim. Dr. Hochman, Boston.
I don't have too much to add. The presentation suggests an abscesses after splenic trauma, rare but possible. He needs a CT scan. Thank you.
Thank you, Dr. Hochman. Dr. Sakrisan, any comment?
Thank you. Yes, I guess with these delayed presentations of solid organ injury patients in general, we worry about delayed bleeds, whether from pseudoaneurysms or delayed splenic rupture. But in this specific case, you're not in class 2, 3, or 4 hemorrhagic shock. We don't know about class 1. They do have a low hemoglobin. Or we worry about septic concerns that everyone's mentioned, abscess, either perisplenic or maybe even liver, or just hematoma in the pelvis getting infected. Or the other thing to consider is sometimes parts of your organ can actually become devascularized during the trauma. It might be frankly necrotic with infected necrosis. So I would go down that route and do what others have mentioned, is get a CT scan. Thank you.
Thank you, Doctor. Dr. Ramos, we will go back to you.
So it's kind of hard for us to get to know exactly what happened at the other hospital. It's like 40 kilometers away from our institution. And he had a summary. That's where we got the information from the grade, the grades of the splenic and hepatic trauma. So Dr. Kasim, we should have done a hemoculture, but we didn't. So we did a CT scan, an angio CT, and a normal scan. Monique? So there was nothing in the pelvis, but as you can see, the spleen was almost, the spleen was almost totally destroyed. And we had a huge hematoma in the left lobe of the liver. So what would you do? And we had fluid in the thorax, as you could see.
Dr. Sakrisan in Toronto.
So again, I'm just in Toronto for vacations, but thank you, and to vote. But so there's a couple of concerns, and I think Flavia, you mentioned there were rib fractures. So there's several areas of septic concerns that I have. Keeping in mind, I believe the patient is not febrile. Is that correct? But yeah,
no, he wasn't. When he was admitted, he wasn't.
Right, but has a leukocytosis. So you're dealing with either
he does.
Inflammatory response, query septic response. You'd think in a young person they would mount a fever, but that's not necessarily always the case. But so now I'm concerned about a retained hemothorax. I could look at the Hounsfield units more clearly to know for sure, but typically any fluid that's associated with rib fractures, even in delayed fashion, is going to be retained hemothorax until proven otherwise. And then the spleen. You can argue, well, should you go after the spleen and remove it? Kind of tricky if, let's say, your blood cultures, if you were to have drawn them, are negative, and this is more of an inflammatory response. How bothered is he by the symptomatology? Would he want to go undergo a laparotomy, to remove the spleen, or is there evidence of any foci of gas? I see none. Anything to suggest that it's actually infected, and like Dr. Kasim had mentioned, any blood cultures. The liver I'm kind of underwhelmed with, and I'm trusting there's also no areas of pseudoaneurysm or anything of concern in the spleen that might tilt me one way or the other towards operative management, but a couple of areas that I'm concerned about for sure. Thank you.
Thank you, Dr. Sakrisan. Dr. Hochman.
Well, I am very unimpressed by the CT scan in terms of an abscess. I think that this patient, looking at that CT, another possibility is that the majority of the splenic parenchyma is gone, and that can cause an elevation of the white count. He has a big hematoma. This looks more like a grade 4 or 5. I don't know. We have to compare with the initial one, but I had the feeling that was misread at the outside hospital. So with no fever, the elevated white count, the elevated protein C, that could also be inflammatory response for this gigantic hematoma, the rib fractures. I wish I'd probably wait. I don't think I will do anything at this time. I will do the blood cultures, maybe something is positive, but otherwise I just watch him. Thank you.
Thank you, Dr. Hochman. Dr. Kasim, your comment, please.
Well, I don't believe this is an abscess, as in this is retained hematoma with the infarction of the with the spleen. I think the spleen looks to me as totally infarcted. In other words, it's dead. And I don't like to leave dead things in the abdominal cavity because invariably it gets into trouble at a later age. So I think I would prophylactically or even therapeutically start him on antibiotic in the form of whatever you want to choose in your hospital. But I would give him a broad spectrum antibiotic, and I would start planning on how am I going to approach this. And before that, I would buck him up with a couple of units of blood because his hemoglobin is low. I want him to be able to tolerate surgery should I get into any trouble with bleeding or etc. And I will make plans to go and tackle this because by and large, I don't like to leave things that don't look perfused well with splenic artery. And I would like to have that removed. Thank you.
Thank you, Dr. Kasim. Dr. Supa, Bangkok.
In this patient, I think I would try to drain with every possible drainable collection. I would drain the fluid in the left chest, and so do the fluid around the left lobe, liver, and around the spleen, and send them for a culture. And I would start, but keep in mind that to drain the splenic collection, we may encounter complication like rupture of the spleen, and we should prepare for laparotomy too. Thank you very much.
Thank you, Dr. Supa. Dr. Fraga.
I'm not comfortable with this image in the spleen because I'm not sure if the patient has access. Can you put the movie again of the CT, Flavia?
Sure,
Please put it
Monique.
again. And I think I agree to start antibiotics, maybe a thoracentesis to look for the leakage in the pleural cavity. Look at this moment, no parenchyma with the spleen. There are places suggest there are recent bleeding. I think it's safer have a surgical treatment for this patient. You can start antibiotic, wait 24 hours, but this patient, I think, needs a surgical treatment. If the team, the group has experience with laparoscopy, they can try, but in my hands, I will start with a laparotomy. I think is safer for the patients and remove the spleen, splenectomy. Thank you.
Doctor. Thank you, Dr. Fraga. Dr. Untrach, and Baghdad.
Yes, I agree with both Dr. Supa and Dr. Fraga. You know, in the history, he was tender over the left upper quadrant, not the epigastrium, where the left lobe, that big hematoma is. So that suggests that really the infection or the problem is in the spleen, and he seems to have a big spherical collection at the spleen that's well encapsulated, or it seems well encapsulated on that image. There's a lot of enhancement. So I suspect that's where the problem is. Laparoscopy, I know, is an option for splenic collections, and I think also in this case, I would speak with the interventionalist to see if they can drain that splenic collection. And then I don't know about the left lobe of the liver. If it's not tender and it seems semi-solid, then I would concentrate more on the splenic collection and also the fluid in the left thorax.
Thank you, Dr. Antrach. Dr. Ramos, we go back to you.
Oh, okay then. So basically we thought the same thing. And we were worried about the fluid in the thorax, and we realized it was an infection, that there wasn't an infection in the hematoma. So Monique, so we decided to start antibiotics and a conservative approach. So we didn't do anything in the abdomen. On the 4th day, we decided to do a thoracentesis, and we had a serohematix secretion with clots. So we decided to put a chest tube. We don't have written how much came out of it. And on the 7th day, we decided to do another CT, like a control, and decided to program an abdominal laparotomy. So this was the CT control after we put a chest tube to the left. As you can see, there is a pneumothorax. And this one looks like there's more fluid than on the first one.
Flavia, can I ask you a quick question while we're scanning?
Yeah,
How is the patient clinically at this point?
it was stable all the time.
And pain worse, better, or the same?
It was the same. He didn't look like he was bad. He was feeling great.
Thank you.
So any
So
comments on the CT?
What kind of fluid did you get? Was it amber? Was it blood clot? Was it anything you can describe the fluid?
It was more of blood, but very fluid and with some clots. When we put the chest tube, right? Any comments on the CT?
Yes, about this chest tube. How was the insertion of the chest tube?
Yeah.
Fifth space? 7, 8, 9,
Yeah.
10.
Yeah.
The chest tube in the
About the chest tube.
the chest tube is very close to the diaphragm. Did you put it on the ultrasound? How did you manage to put it there? Make sure it's not
Exactly.
too low.
Yeah, we had a problem
And
there.
the splenic fluid is drained, so I had the feeling that the chest tube served as a percutaneous drainage of the.
Exactly. Exactly. We had a problem there with the chest tube. As you can see, the chest tube is not in the
We call
thorax.
those
It's in the
challenges.
abdomen.
Not problems, challenges.
Challenge. Probably the resident told you, oh, I was thinking the problem was in the spleen, so I put the drain in the spleen. That's a problem.
Yeah. Yeah,
We're
the
serious.
idea, the resident told us that his idea was to try to put it as low as possible. So it was a bit lower than he expected. So, Monique. So we decided to do a laparotomy, Monique. And that's what we found. We had a hepatic hematoma. It was huge. And he was completely connected to the spleen. There were lots of adhesions, very strong adhesions. Our idea was not to touch the hepatic hematoma, but it didn't work. It just burst into our hands when we were trying to release the spleen. And it was really rough, like an inflammatory mass. And we had a hard time taking it out. So that's what it looked like after the hematoma just burst. And that's the spleen in our hands. So we ended up doing an splenectomy. We did drain the hepatic hematoma. It wasn't bleeding at the time. It did burst, but there was no active bleeding. So we put a chest tube in the abdomen to drain in case there was anything left there. And we opened up the diaphragm and we washed the thorax through to the abdomen. And we put a chest tube correctly this time. So this is the repair of the diaphragm after we opened it. And that's what the spleen looked like.
Flavia.
Any comments? Yeah.
Yes, so just a question. Do you have a thoracoscopy in the hospital? The vest to
No.
perform a thoracoscopy instead of open the diaphragm? Is it available in the hospital, thoracoscopy?
Yeah, we did think about it. We did think about doing thoracoscopy, but since we are with the abdomen open, we went to the diaphragm.
Dr. Ramos, would you like to get comments from the panelists?
Yeah.
Okay. Dr. Antrash, any comments?
Any comments?
Yes. Well, very well done. So everything is taken care of in the abdomen. The only thing in the chest in that last CAT scan, or the second CT, the one that you did at your hospital, it looked like there was a bit of a pneumothorax anteriorly. The lung wasn't fully expanded, and there was blood in the chest for a couple of weeks. So I'd be concerned about a fibrothorax. And although since you were in the abdomen doing what you did, I thought was fine, but I suppose he may wind up needing a decortication if the lung doesn't fully expand as you follow him. But that's my only concern. Otherwise, I think everything looks good for what you did.
Thank you, Dr. Antrash. Dr. Kasim, any comments?
Well, you went through the diaphragm and you washed out the left pleural cavity. Am I right? Did you go through the diaphragm and wash out the left pleural cavity?
Exactly.
Exactly. So essentially, she has evacuated the retained hemothorax in the left pleural cavity, whereby she probably circumvented the possibility of left fibrothorax. So it may reaccumulate, but we'll see how it happens. But I think you have done what you set out to do. You had a rupture of the hematoma in your hand, and you took care of it. And the spleen is well attached to this hematoma, and you took out en masse all the possibility of retained hemothorax, retained hematoma in the left lobe of the liver. And I don't know how you close the residual left lobe of the liver, whether it looked pristine or whether it looked reasonable to you, and you put a chest tube in that area. And those are all well accepted in my hand. And now you're dealing with closure of the abdomen and you're closest to a diaphragmatic incision as well. So all in all, you've done very well, I must say. I'm impressed. Thank you.
Thank you, Dr. Kasim. Dr. Rahman, Boston.
I think it goes through, I don't know, maybe I'm too crazy, but I think that going through the diaphragm for me makes a lot of sense. You have already hole in the diaphragm. So what is the problem? You just go there, clean the chest from there, you will have a very good view. You can use a scope if you need to make sure that you are not missing anything. After that, put a regular chest tube, or if there is not too much there, just use many times I use a rubber catheter before tying the last suture, suck all the air and see what happens. But yeah, I don't see anything wrong of this approach. Quite the opposite. I think it's a very smart approach than doing a thoracotomy or trying to put it blindly another chest tube in something that might be loculated. Regarding the spleen and the liver, yeah, I kind of expected that was going to be the finding. Everything is very adherent to each other, very difficult to separate so far out. I would like to ask Flavia, would you consider not operating on this guy? You have the drain in a serendipitous way. The drain went into the right place, so maybe that's all he needed. Was he doing okay? What was the decision to operate?
Well, actually, the drain dissected the spleen. The capsule was right under the capsule.
Yeah, but the guy was doing okay. It's like you would put a percutaneous drain in a, sometimes this hematomas liquefied and they have a big hygroma that we put a drain there just to reduce the volume because they cause gastric outlet gastric obstruction or early satiety. And we do it percutaneously because the rest of the abdomen is kind of sealed. So I don't know.
Yeah, but he had more clots than fluid. Okay. Yeah, it's way more dense, the fluid. So I don't think it would have worked. And we were worried about the chest tube in the abdomen. We didn't know exactly where it was.
I cannot criticize you on anything. As a matter of fact, I think the management was excellent. Thank you.
Thank you, Dr. Rahman.
Thank
Dr.
you.
Sakelson.
Thank you, Dr. Ramos, for an excellent presentation, excellent photos, and great tomography. And it's, as always, wonderful to hear about your cases from Brazil and to see your smiling face. So very interesting. I would, sort of highlight some of the similar points that Dr. Hoffman was saying in terms of the potential for non-operative management. I think if this patient has returned to hospital, his pain is debilitating, he can't go back to work, can't go back to school or whatever he does, then you're basically doing, as you did the splenectomy, not for bleeding reasons, not for clear septic reasons, but because for symptoms. And that is absolutely fine. I would agree what has been highlighted, that it really is important to address any retained hemothorax in a timely fashion. As we all know on the call, we try to do that within 72 hours of trauma. You didn't have that luxury because he presented so late. And the later they are, more of that fibrothorax that Stephen mentioned tends to form, and it is important to clear that all out. So that's great that you did that. I think I just want to end with a quick question for you, Flavia, if I may. We were sort of laughing and joking a bit about the positioning of the chest tube, but in your hospital and on the trauma service, or do you have any like quality assurance or do you do M&Ms in your hospital, or is there any mechanism to actually talk about these complications that are not uncommon around the world, to be honest? Do you have some mechanism to deal with that so that as a system we can improve and try to avoid that complication? That's a question I have for all of my colleagues around the Americas, because I think that's really important. And peer-reviewed panels in trauma have been one of the few things that have actually shown to have a mortality benefit from a quality perspective. So that's just my own curious thing, just enjoying quality. But thank you, Flavia, and congratulations on an excellent case and presentation.
Thank you, Tanya, for the observation. Actually, we don't. We did talk to the residents. We talked about it, we discussed it, but it's not a hospital system. Not really. we have a problem with the who runs the hospital. So it changes. Like I've been there since 2013, and we had like 4 bosses till now. So every time it changes, who's hiring us, we have a problem. Everything changes. We have to recreate everything. And this new, we call it social organization, who's ruling us now. It's been there for like a year and a half. So they're still trying to organize everything. So we don't.
So it sounds like you're demonstrating leadership yourself within the surgical group about even having these meetings with the residents.
Exactly.
With your colleagues.
Exactly.
And I applaud you. I really applaud you for that, because that's difficult when leadership is shifting or kind of focused on other things. So, you know, and it's hard. People don't want another meeting, but it is very important. So thank you for doing that. And I would be interested to know if other people in other institutions are doing that, if they want to mention it in the chat, if they're interested. Thank you, Flavia. Congratulations for that systems improvement.
Thank you. Our chief, the chief of surgery, he's the one who's in charge of that. He's the one who talks to the residents and to the surgeons and discuss the outcomes of the patients. So.
Thank you, Dr. Sacristán. Dr. Fraga Campinas.
Congratulations, Flavia. It's a very difficult case. The first problem when we receive the trauma surgeons, we like to operate patients. But everyone, I think, in this conference, like non-operative treatments. But about the non-operative treatments, you do a lot of this treatment here in our hospital. I think the patient, he has only one opportunity to have a good evolution. If he starts to have complication, I think it's the moment to think about a surgical treatment, because you have a splenic and a hepatic injury. And 15 days later, usually the patient is totally recovered. The patient is okay. If he starts to have complication, I prefer for invasive approach and probably go direct to laparotomy, do the same antibiotics, thoracentesis to look at the effusion, pleural effusion, etc. But about the surgical treatment, 1 week after the admission at the hospital, there was a complication. It happens in all hospitals in the world, and congratulations to show us this complication, because we learn with the errors of the others and our errors, and need to revise the case and learn more with the patients, with the case. So congratulations to show us this case. And about the approach to the pleural cavity, if you have a thoracoscopy available, I don't like the idea to open the diaphragm, because the diaphragm was intact. You cannot have good to wash adequately through the diaphragm. If you put the camera, the thoracoscopy, you can have more possibility to clean the pleural cavity. In my opinion, I think it's better, but you need to have the equipment. You have the surgeon with experience to do this surgical procedure. But congratulations to show us this case, very interesting. And the next case that came to my hospital with a complication in the spleen, I think I will be more attempt to indicate a surgical treatment very soon, because I think it's better for the patients. Thank you.
Let me just complement Dr. Fraga's point here. Dr. Flavia Ramos, if you had the CAT scan at the first admission, I know it was not in your hospital. If any of you guys had a CAT scan at the first admission, the follow-up, would you do something? Because that's a good question, because I remember while I was in Brazil before moving to the United States, for all this grade 3, 4 splenic injury that it did no operative management, the protocol of my hospital was to do a follow-up before discharge in 1 week with an ultrasound, not a CAT scan, ultrasound. So the ultrasound could see the parenchyma, the spleen, could see the hematoma, could even see a pseudoaneurysm. I know this is not part of the guidelines. We're not going to do another CAT scan. We don't do a lot of ultrasounds here for solid organ injury. Do CAT scan will be another lot of radiation. But for all your guys, if you had this follow-up CAT scan at day 7, just before discharging this patient at the first admission, would you do something? That's my question for you, because maybe sometimes I discharge some patient without seeing what's happening, and maybe discharge some patient with aneurysm in place, but a lot of hematomas, and this patient going to complicate later. Just a question for everybody, please. Valeria, let's ask everybody's opinion, please.
Well, in Brazil, in Caxias, where we work, probably not, because he would have to stop working and stay home for a while in case with the risk of rupture, and that doesn't happen there. They don't do what we told them to do, so it would be a very high risk, and he could die at home. So probably would operate.
Thank you, Dr. Ramos. Dr. Supa, Bangkok.
In this patient, I was talking to the resident here that the landmark for chest tube insertion may be higher than the typical one that we use to insert the chest tube, because he had like left subdiaphragmatic collection, which pushed the diaphragm up. So to be safe in this patient, we should have used like a ultrasound guide for the insertion of the chest tube, or you can talk to the radiologist and ask them to mark the intercostal space that is safe for chest tube insertion. And my second point, I agree with laparotomy in this patient, because the clot around the spleen and the liver can look, they look thick, and I don't think they could be drained by percutaneous drainage. So open surgery to drain those hematoma that may be infected, I think it's a good idea. And I like the idea of draining the chest collection via the diaphragm. You don't have to reposition the patient and to put the scope or do the thoracotomy. But in my opinion, I think we need a big hole in the diaphragm in order to put our hand through the diaphragm and to try to clear out the clot and the septation that he may have. And for Dr. Matos' question, if we have the on day 7 after the injury and we found hematoma around the liver and the spleen, I will check how he does. If the patient is doing well, no abdominal pain, no anemia, no fever, I would just observe him maybe few more days in the hospital. But if he had symptoms like fever or abdominal pain, I would drain the collection percutaneously. Thank you.
Thank you, Dr. Supa. Dr. Antract, Baghdad.
Yes, I recall that Dr. Fraga had several cases of non-operative management of high-grade splenic ruptures, or at least one, where the bleeding stopped, but at discharge, the follow-up CAT scan, there was still a lot of blood around the spleen, and the patient was otherwise fine. It was non-tender, so nothing more was done, and the patient then did fine after that. So I think in this case, as Dr. Supa said, you would expect a large collection, but it sounds like the patient did not have symptoms when he was discharged from the first hospital. They appeared later. So I think that's reasonable. And then Dr. Fraga's comments, I think that's the takeaway lesson. Dr. Fraga at his hospital, from all the cases he's presented, I can see he's a big fan of aggressive use of interventional radiology to take care of these injuries, including high-grade injuries of the spleen, and they work just fine. And in this case, he would not use percutaneous treatment because the original treatment failed. So that's something that I'll remember. If the patient comes back with a complication, then it's time for a laparotomy, as he said. So I think that was a good point on his part.
Thank you, Dr. Dr. Kasim, Portland.
Well, the dictum in surgery is you cannot make a patient feel better when he's already feeling better. If this patient wouldn't have any symptoms, he wouldn't have come to you. He would have stayed home. He would have carried on. Slowly, the hematoma would have resolved, and he would be on his way to full recovery. And because he was having symptoms, he sought medical help from experts like you. And the problem is what to do when he comes in with symptoms of not feeling well, with a hemoglobin of 8, and he has all the other supporting evidence of possible infection or infarction or sepsis, and you have to do something. In my opinion, a hematoma which is 15 days old, you can't drain it with a chest tube. You can't drain it with percutaneous tube. You know, they need to have a proper evacuation because it's all clotted. And as you saw, the amount of clot you had in the left lobe of the liver was enormous. It almost ruptured. It definitely ruptured in your hand. So I think as surgeons, there is a lot of talk of NOM in splenic injury, but I think you have to reevaluate this. And not all patients are candidates for NOM in splenic injury. And over 90% of the patients are being treated with NOM in the United States at this moment. But don't forget, the mortality of these patients who are getting this NOM treatment is 0.7 to 1.5. It's significant because I don't believe doing a splenectomy carries that kind of mortality. Because once you get into problems with NOM, sepsis, etc., it is a cascade, it doesn't stop. Now, regarding the question Dr. Martos asked, by and large, patients who get discharged on the 5th day following splenic injury with NOM, they should be followed up by the attending physician or his subordinate by telephone calls on a regular basis to make sure that he is progressing well at home. If not, he needs to be re-evaluated at the institution where he asks for treatment initially, not come to a secondary hospital like yours, or at least have the information sent to you for follow-up. I think follow-up is very, very important when you establish non-operative management. The non-operative management of spleen is a panacea, and I think it is being overused with no proper follow-up. They go from one hospital to the other hospital. Thank you.
Thank you, Dr. Kasim. Dr. Ochman?
I don't have too much to add to whatever was discussed. I will second Dr. Sacristán's comments about having a PI system that we all make mistakes. There is the only people who do not make mistakes are the people who do not do surgery. But if you are a surgeon, you are going to make mistakes. You are going to have complications. And many years ago, I learned that smart people learn from other people's mistakes. Normal people learn from their own mistakes, and stupid people do not learn even from their own mistakes. So I would like to think that people here are smart, so we can learn from each other's mistakes. And I think that having a PI system, in the sense that having either trauma or surgery, morbidity and mortality conference, and for issues that only relate to surgery, or having a multidisciplinary conference for issues that involve more than trauma, like when you have a problem with orthopedics and anesthesia and neurosurgery and overlapping roles is critical to move the scenes forward. And Antonio, maybe there is something that the Panamerican Trauma Society should look, trying to implement something like this, or maybe some guidelines, particularly helping, because anyone can read in any journal what to do, what about this or that pathology, but how to deal with the complications is kind of more like the way we do the things locally in each hospital. And I think everybody can learn, and implementing these systems, it will do a lot to move things forward in many places. So that would be I second Tanya's suggestions and doing something like this.
Thank you, Dr. Sacrison. Any comments?
Thank you so much. Thank you. Yes, I think yeah, that's very exciting to hear Guille and Flavia, to hear all of our colleagues and friends on the call talk about these initiatives. Back to the question, and to the question that Tony was asking, you know, it's really interesting, Flavia, if this patient came in after blunt trauma, had a bit of pain, let's pretend he had nothing wrong with the chest, because that's, you know, a bit of another discussion, but he presented because he had discomfort related to inflammation, not infection, in his abdomen, at least for the time being. Objectively, we would have to, I personally feel that I would have to be hard pressed to operate on him, meaning the pain was debilitating and it wasn't, you know, something that you could reassure the patient to say, hey, let's bring you back to clinic in a couple of weeks, keep following you with serial imaging. I think the question is really interesting. There's a lot of literature, pro, con, about solid organ injury, grade 3, 4, 5 and above. What do you do prior to discharge? Imaging wise, to look for those pseudoaneurysms, which are my kind of main concern. Septic concerns, I think, will manifest clinically. The patient will kind of tell you they're septic with the fevers, chills, blood cultures, and the pain. And this patient might have been heading towards that. I probably would have watched him non-operatively, but it really depends on the patient. Again, if the symptomatology was so debilitating in his case, then sure, you can operate for symptoms. But if he just needed reassurance, I might have just watched him. And then the question is also interesting, what to do with the repeat imaging, where you see 50% of complications like those pseudoaneurysms in the blunt trauma. How often do you see them in the penetrating trauma? I'm thinking of the liver. How often should we be routinely, you know, re-imaging those people that get that transliver gunshot wound that's pretty debilitating and whatnot, that maybe is non-operative or whatnot? That's something we're looking at now on the south side of Chicago here. But very interesting case, and I always love hearing the opinions of everyone else. So thank you so much.
Thank you, Dr. Sacrison. Dr. Ramos, we go back to you.
Or the chief of surgery has started a morbidity and mortality meetings. So we'll be discussing more about this. We do have an outpatient clinic at our hospital, and we do continue seeing, we have a follow-up of trauma patients in our hospital. So on the 12th day of hospitalization, the patient developed fever and altered inflammatory markers, but he was still stable. The abdominal drain had a fluid hepatic secretion, and the chest tube was a very bright secretion, like kind of a orange, like, and both with low output. So we decided to change the antibiotic to a larger spectrum, and we did another CT scan of the chest and the abdomen, basically because of the same worry. I don't really remember who talked about it, the problem with the lung, that it could be incarcerated. So we were concerned about that. Monique? So there's still some fluid in the chest. And you can see that the chest tube in the abdomen was exactly where the hepatic hematoma was. And the patient was stable, and we decided to take out the chest tube and improve physical therapy, respiratory therapy, and we kept the abdominal drain. Monique? So he had an laboratory improvement after we changed the spectrum of the antibiotics. So we decided to discharge him. He already came back to our follow-up. I'm the one who does it. And he was fine, no abdominal pain, no tenderness. He was totally asymptomatic, no fever, and we're still waiting for the results of the biopsy. So, any comments? Thank you very much for your time and attention.
Thank you, Dr. Ramos. Dr. Martos, any comments?
Dr. Martos.
Yes, Dr. Flavia.
I don't know if you have access to the chat with some important thing that some colleagues wrote in the chat, but I think it's very important you read some comments in the chat, because you are the surgeon from Brazil with a wonderful career as a trauma surgeon in the United States, and you know all problems that you have in Brazil. And you are the one that in 2010 started to organize this meeting. So we have 11 years with this meeting organized by University of Miami, and some years later as a Panamerican Trauma Society meeting, but the idea came from University of Miami. And everyone who had time to join this meeting learned a lot about trauma, because you have meetings every week, probably more than 1,000 meetings were organized. And when you discuss cases from Brazil, usually you have the same problem. You know the problems from Brazil. We don't have an organized trauma system. This is the main problem in our country. Just congratulate you that have worked hard to change this in our country. This hospital in Rio de Janeiro, I know this hospital, was one of 2 hospitals who received support, international support, to organize a trauma center. So they have 2 trauma centers in Rio de Janeiro, but they don't have a system. So this is a very good example. The patient was treated in another hospital, you have few information in another hospital, you don't receive the information. So you have a lot to improve. I don't know if you have time to improve, you and me, because you are becoming older and you are a little tired to try to change some political problems and problems in the society, etc. But just to congratulate you, Antonio, to start this teleconference. Someone wrote about organize a morbidity and mortality meeting. This is a perfect moment to do this, because you can discuss the case with other specialists. Someone wrote about having a multidisciplinary team discuss the cases. It's very, very important. You have the anesthetists, emergency medicine, and the others, nurses, neurosurgeons, orthopedics, discuss the case with us. But it's very difficult to start this system in Brazil. And it's the only way to improve the treatment of the trauma patients. United States, you did this in 1966, maybe more than 50 years ago, and you need to improve the system in Brazil. Just this comment, and congratulations to Dr. Antonio Martos.
So, Fraga, thanks for your words, but I need to really congratulate the physicians from Rio de Janeiro. Some of you know, but in Rio de Janeiro, they try to improve the system before the FIFA Soccer World Cup in 2014 and the Olympic Games 2016. And we are invited to University of Miami to be part of this process. University of Maryland, Baltimore also did part of this process for training, etc. And we met so many talented people over there. Like Flavia Ramos is a star. Paulo Silveira, there's a chief of trauma at Hippen, is a star, a great friend. Dr. Bruno Vaz, Dr. Helio Penas. I'm not gonna keep mentioning people. There's so many excellent surgeons, physicians, human beings, you know, that work very hard to make it for their patients, you know. And we help them to have physicians coming to Miami to learn how the USA system. Then you went there for 1 year, going 1 week every month, try to work with them, do briefing, debrief, implement protocols, guidelines, etc. And I would say I'm very proud to see that these two hospitals, the HIT and the Hippen, two public hospitals, they had a lot of problems, and despite still having problems, like Flavia said, changed administration 4 times in this short period, and have political issues, economic issues, etc. They are still operating as a trauma center. They are still running with quality control. They had before they stopped, they come back with M&M, etc., etc. So I would say that once you do the right thing, once you learn how to do the trauma the right way, it's impossible to come back. And that's what this group said to me. Once you learn how to do the pit stop, or the trauma bay, it's impossible to go to another place and don't do the right way. So I would say, Fraga, I did nothing, you know. Flavia, Paulo, Bruno, Helio, and every other son, all the physicians that I know that work with trauma for decades in Brazil, they are the heroes because they have been working multiple times under not ideal situation, ideal conditions. They have a heavy load of trauma and they do the best and have great results, you know. So I'm very proud to see Flavia, you presenting today. I hope you can present more time. The HIT and the Hippen can present more often, because it's important to show that even not having the best CAT scan, sometimes don't have angioembolization available, etc. With the resource that you have and the talent of the physicians, the talent, the hard working, we can save trauma patients. I think that's what have been showing for this meeting, in this meeting for 11 years, because we give the opportunity to place around the globe, in South America, in Europe, in Middle East, etc., in Asia, to show how they treat trauma patients with the conditions that they have. And that's what matters, you know, to show how you can do our best for trauma patients, wherever you are, with the research that you have. So I really need to applaud Flavia for the presentation today, and say that we are very proud of you, and I'm very proud of all physicians, nurses, healthcare professionals in Rio de Janeiro that have been working hard for decades to take care of our trauma patients, and multiple times in situations of mass casualty shootings or multiple car crash, etc. You guys have been amazing. You guys are heroes. You guys just deserve all your applause. Okay, it's for you. And just to complement Dr. Fraga, so the Panamerican Society is going to launch a brand new platform. It's not a website, it's a platform next month, where you should be able to have forums. You can put your case, you can discuss with other physicians. And again, we think about bringing this kind of educational interaction for the next level. And this is only going to happen because of you all, you know, excellent physicians, nurses, healthcare professionals, surgeons, that are here to discuss case and to spend some time exchange information, knowledge, and trauma. Thank you.
Thank you, everyone. Thank you, Dr. Martos. And next week we have a case from Ryder, so please, everyone is invited to join. Have a good day.
Obrigado, Flavia.
Thank you very much.
Congratulations, Flavia, to present the case. Congratulations.
Thank you very much.